This video is intended to help you aid your clinical reasoning by developing a diagnostic framework for a child with a limp. It should hopefully make it easier to consider differential diagnoses in a more structured way. We'll also discuss some examples of cognitive bias, which can result in diagnostic error. Let's start with a case scenario. You're a GP working in Sydney, and your colleague brings in his 13-year-old son, Timmy, who's been limping for about a month. Just like his orthopedic surgeon dad, he's excessively large, muscular, looking more like your F45 instructor than a boy in year 7. He's got right-sided hip, groin, and medial knee pain, and on physical exam, the affected leg is externally rotated, and there's a limited range of movement of the hip. His dad says that since completing his fellowship in upper limb orthopedic surgery, he doesn't do legs, and he wouldn't be confident in his own diagnosis anyway. He shamefully reports that Timmy's also lost weight recently and can't max out the bench press machine in the gym. This makes him so worried that the most likely differential is actually a malignancy like osteosarcoma. Partially deaf because his external ear is obstructed by his overly developed head muscles, you speak loud and slow enough for your colleague to hear your own diagnostic framework for a limping child. Although there are several approaches, one way to think about a non-weight bearing kid is to first consider important conditions in different age groups. I like to break it down into 3 groups and remember the mnemonic THC is so good. A little naughty, but it does the trick. Between 0 and 5, toddler's fractures, a first presentation of haemophilia causing hemarthrosis, and congenital hip dysplasia are good things to consider. Between 5 to 10, idiopathic avascular necrosis of the femoral head, also known as leg-calf-Perthes disease, and transient synovitis of the hip are important differentials. Finally, between 10 to 15, a slipped upper femoral epiphysis, or SUFI, and traction apophysitis from something like Osgood-Schlatters are good differentials. It's important to remember that many causes of limp aren't actually age-specific, and a broader diagnostic framework might actually work better sometimes. Although systems reviews are good, sometimes it's important to think about causes based on severity. Consider emergencies like septic arthritis and osteomyelitis, non-emergent severe diseases like malignancies, chronic illnesses like rheumatological disorders, and benign issues like musculoskeletal issues. Back to our case, it seems like Timmy, our 13-year-old boy, has many classic features of a slipped upper femoral epiphysis. You can remember some of these features in the rhyme, overweight, mate, with a painful gait that externally rotates. However, it's important to note that he is kind of presenting atypically with weight loss, and that's really why his father was concerned about osteosarcoma as the most likely differential. This highlights a common cognitive bias in medicine, where doctors often mistakenly think an atypical presentation of a common disease is more likely to be a rare condition that fits in with those atypical features. This is known as the base rate fallacy, which is perfectly illustrated by Theodore Woodward's saying, "When you hear hoofbeats behind you, look for horses and not zebras." Maybe it's more likely Timmy has lost weight for other reasons, like he's stopped going to the gym because he wants to be a psychiatrist and not a medical carpenter like his dad. To review, sometimes multiple diagnostic frameworks are better than just one. THC is so good is just one way to remember important causes of limps by age group. Differentials based on severity can help you consider important not to miss illnesses. And remember, when you hear hoofbeats behind you, look for horses first and not zebras. However, zebras really are out there. Thanks for watching Townsend Teachings. Don't forget to hit the notification bell, like, comment, and subscribe.